All right. So it's 2:30 sharp, but many of you have been waiting for quite a while, so I think we should get started. So welcome and good afternoon. This is the symposium entitled Towards HIV Elimination. I'm François Dabis. I'm the director of the French National AIDS Research Agency and on HIV and viral hepatitis. And I will be co-chairing this session with Adel Benzakem, who is the director of the HIV, STI, and viral hepatitis program of the Ministry of Health of Brazil. So we are delighted to be here with you. This session comes from a basic, principle, is that certainly to reach the global target of ending HIV/AIDS, we will need solid strategies and probably new elements in the field of cure, in the field of vaccine, and from there develop an elimination plan. However, this is not going to be achieved soon. We all agree on that. But nevertheless, we have several approaches that we know have been effectively shown to reduce and limit transmission. Most of it was known well before this conference. Simply new evidence has come from this conference. And the tools that are needed to success for preventing transmission already exist. And I'll just remind this distinguished audience that they are based on several aspects. First of all, the engagement of key populations. 2, the high coverage of prevention on HIV prevention and testing. 3, the immediate ARV treatment for all people living with HIV with the objective and the guarantee that they achieve viral suppression. Voluntary medical male circumcision, which was maybe not very much presented in this conference, and harm reduction. So we have these tools, we know them, we have known them for several years, for several of them, for less long time for others. But yet, turning these tools into practice has been proven challenging in many settings. So the symposium was developed with the idea to discuss and share new evidence and discuss them, put them into perspectives, and assembling a group that probably, as shown in this room, has policymakers, implementations, researchers, program managers, advocates, and certainly scientists from other fields. So we hope that we will present evidence in this symposium in different settings, that we have the opportunity to discuss the effectiveness in real life of the strategies that could lead to first the control and then ultimately to elimination, and have an open dialogue on where the remaining obstacles and questions that remain in this field, and how, especially for scientists, we can translate and we have to translate that into further research. So unfortunately, we don't have all the presenters on that were mapped on the agenda today, but we have 3 or 4 very distinguished presenters with a lot of expertise and experience to share today, and I'm sure with each of them we will have a different angle of appreciation of the issues that I just described. So I'll pass on to you for introducing the first speaker.
Bonjour, mesdames, messieurs. It's my pleasure to introduce for some preliminary comments Marika Windenbrooks. She's from Global Fund to fight AIDS, tuberculosis, and malaria, and she joined the Global Fund since 2013. And she's responsible for focus particular in gender and human rights. And in June of 2017, she is an executive director of the Global Fund. And before that, she had a lot of experience,
Yeah.
and in WHO, in different countries, and the Minister of Foreign Affairs. So she's a woman with a lot of experience, and she's gonna do some introduction comments.
Thank you very much for that kind introduction. And this is really meant to have to make a few brief comments to frame the discussion. And it's unfortunate some of the presenters that I had been looking forward to listening dropped off the agenda. But it's fantastic to see that we have such large participation. So I think for the discussion, we're going to rely a lot on your experience and bright thinking. Just for me, one of the key messages coming out of the Paris meeting, and I've been only following a snapshot of all the sessions, was the continued success of the treatment scale-up, and very encouraging report by PEPFAR earlier this week by the number of countries that have seen successful treatment scale-up with high levels of viral suppression and declining incidence. And those are really collective successes by the entire partnership at country level. And those are really encouraging signs that HIV elimination might be a feasible target by 2030 to eliminate HIV as a public health crisis. So there's a lot of encouraging news coming out of these reports. But we also know, just looking at the UNAIDS report that was published last week, that incidence is not declining in all regions, and actually in some regions, the number of new infections continues to increase. And globally, incidence is not declining at the speed and the rate that we need. So we need to continue investing in scaling up treatment programs, but we also have to invest more in primary prevention. And we have to invest in new tools for prevention, a cure or prolonged viral suppression, and the sort of the long-term goal of effective HIV vaccine. But given where we are, and as the chair explained in his introduction, we also must understand why the current effective prevention tools we have are not used at the scale that we think they could be used or should be used. And for some of these prevention tools, we know quite well why they are not used optimally. Harm reduction was mentioned, one of the most cost-effective prevention tools. But we know that implementation in many countries is difficult because of political, human rights and legal barriers, and sadly, mostly a combination of those two. We know that consistent condom use is highly effective in preventing HIV transmission. But we also know that gender barriers make it really difficult for women to negotiate condom use. And more globally, consistent condom use requires that people make rational decisions at a moment that they're probably least inclined to take any rational decision. So we understand why consistent condom use is really difficult. And then there's a lot of prevention tools where I think we really don't have the solid understanding of why there's not a lot of uptake. The voluntary male circumcision was mentioned, which is really promising and was in one of the earlier AIDS conferences introduced with a lot of promise and what the impact might be, but uptake across the high impact countries has been pretty low. I was struck by the dipivirine ring results that were presented that had very low effectiveness in the younger age groups. And actually, when they did research, a lot of the young women, so they didn't use it. And it's not just that they didn't use the ring. After going to the clinic where the ring was inserted, and they came home and they took the ring out, so there was actually active non-adherence. So we need to understand why this is happening and why young women don't like it, like that tool. And PrEP, I think, a very promising tool, but also with very different impact and efficiencies in different populations. So again, there we need to understand why is uptake low and efficiency low in certain population groups. There's, I think, a lot of good brains in the panel. There's a lot of very bright people in the audience. So I hope that we can develop some of that understanding, or at least develop a shared agenda of where we need to do further research. Thank you.
Thank you very much, Marike, and I think you will be part of the panel for questions afterwards. But we believe that to understand whether what's happening and where the gaps are, epidemiology is still an important contribution. And we are very fortunate to have Peter Gies here today to tell us about the overview on the trends in reducing HIV transmission and incidence. Peter is the interim director of the UNAIDS Strategic Information and Evaluation Department. His department generates and promotes the use of strategic information to improve the efficiency and effectiveness of national AIDS programs and the UN actions that support them. And he has been extremely contributive over the past long time ago, maybe more than 15 years, in developing the necessary information systems all over the world and at the UNAIDS headquarters to have a clear picture on which he's going to report today. He is the one in charge of basically putting the data together each year that we all are eagerly waiting. So Peter, you have the floor.
Thanks a lot, Francois, and thanks for having me in this symposium. So as Francois has explained, I will just give you like an overview of the trends as we see them in the epidemic with a focus on incidence. And all right, we have time, so thank you. So what I will tell you about is just a brief introduction to which is really about targets that we have today. Then we'll look at trends in new infections, but at a global level. From there, we'll look more closely at what is happening with new infections among adults. And we'll do that both by regions and for selected countries. And then next, we'll shift to HIV, to looking at HIV transmission rates, again for adults, and then we'll come back to the example that was already mentioned by Mareike in Swaziland before I conclude. So for the introduction, just to say that probably the most visible target in people's minds is indeed this reduction in the number of new infections by 75% between 2010 and the year 2020. With the aim of bringing that number to less than 500,000 new infections in the year 2020. As I mentioned, I will also speak to transmission rate. There is not a specific target today for that transmission rate. And then in relation to Swaziland, I will actually talk about incidence rate. And so incidence rate, again, maybe there's no consensus about what a target incidence rate is, but at least some researchers have used a target incidence rate of 0.1% per year. And of course, much of the modeling that this group has done has been for South Africa, so not clear that that would be like applicable for other countries. So just to explain briefly where this target comes from, to say that like modeling was done like 2 or 3 years ago to look at what would be the impact if we brought to bear all the currently available interventions to the AIDS response and do that in an optimal way. So modeling then suggests that if that indeed is done, then we would bring down the number of new infections to below 500,000, as you can see in the red line here for the year 2020. So that's really the origin of that target. And as Francois mentioned, it includes the effects of a range of interventions that go from treatment to condom programming, male circumcision, PrEP, interventions for key populations, and specifically harm reduction for people who inject drugs, but also prevention of mother-to-child transmission for the new infection in children, and finally also cash transfers. And then besides all of these interventions for which there is an estimate of its efficacy, of the effect that it has on incidence, there is also attention for enabling factors that make for a right policy environment so that these interventions can have the effects that are applied in the model. So next, I will just briefly give you the trends in new infections at the global level. And so the first slide here is for all ages from 1999 to 2016. And you also see the target that I just described for the year 2020. And so it looks like the world is really not on track to achieve that. This slide is for children. So here we see like a very dramatic reduction in the number of children that are newly infected, as well as the target that is set for 2020. And so just looking at this slide, it looks like with ongoing efforts that, yes, the world could make that target. Then the third slide here is about adults. So this looks a little bit less favorable still than the initial slide that we saw about all ages, where really we have to conclude that we're not on track to reach that target, because we have about 1.8 million new infections in the year 2016. And that, as I said, should be brought to less than 500,000 per year in the year 2020. So next, then, I will have a look at the similar data for adults, though, by region. And then after that, we'll go into selected countries. So this is a little bit of a complex slide, so I'll take some time to go through this. But it shows the number of new infections in adults for the different regions. So again, the time scale is 1999 to 2016. And the little images for each of the region also show the percentage decline in new infections between the years 2010 and 2016. So the first thing to be aware of is that the scale of these little graphs is all very different, with the largest numbers, of course, in East and Southern Africa. And so the largest decline is also in that same region. Of course, East and Southern Africa is the region that has most people living with HIV, but also most new infections. And so the decline between 2010 and 2016 is of 24%. Then the region just below that is Eastern Europe and Central Asia. There was already some reference to that to show that it's really the one region where we're going in the wrong direction, where there is an increase in the number of new infections instead of a decrease. And so the increase is of 60% between 2010 and 2020. No, sorry, 2010 and 2016. So then the other regions, you can see that there is a decline for all of them, but variable by region. And so the decline is also less than the decline that we see in East and Southern Africa. So the decline ranges from zero, close to 0% in the Caribbean region, up to 9% decline, or 11% decline, sorry, in Asia and Pacific region. So next, I will just look at a few countries, a few country examples of those declines. And I had deliberately left out Botswana and Cambodia since they were going to be on the panel, but not now. So just looking at these countries, so we see that, yes, there is also important declines in several countries, up to 42% we have here for Zimbabwe. Again, this is for the period between 2010 and 2016. And so examples are shown for Malawi, Mozambique, South Africa on top, and Uganda and Zimbabwe on the second row. So moving to West and Central Africa, again, we have several examples of countries that have important declines in new infections. Here it's between 14% and 23%, including Côte d'Ivoire, DRC, and Gabon. So moving along just to other regions of the globe to show that elsewhere also there is important declines, with a very strong decline showing in Thailand, but also Morocco, Nicaragua, Haiti. again, the scales of these that are used in these graphs will be very different from one country to another, where a country like Morocco and Nicaragua just have like a comparatively small number of new infections as we compare them to Thailand or Haiti. So next, I will turn to transmission rate. And so before I show you the data, which is going to be by region, similar to what I showed for number of new infections, to say that the transmission rate is calculated as the number of new infections in a year divided by all people living with HIV in that same year. So this is a similar image as we've seen for new infections. So this time it shows the transmission rate, as I've just explained. It is number of new infections divided by number of people living with HIV in that region. And you see that pretty much for all regions it is declining, except for Eastern Europe and Central Asia, where it seems to be pretty stable. Also, you will see that the scale of these graphs is all the same. It all goes to 100%. And right, and so the declines that we see in these different regions, they range from 3% in West and Central Europe and North America, which is grouped together, up to 8% in the Middle East and North Africa, with just drawing attention of 4% decrease in the Eastern and Southern Africa region. As we mentioned, that's the region that has most new infections in the world. So from here then we'll just briefly discuss the Swaziland, which has been presented with its incidence rate. And so that is a result that was presented in this conference on Monday morning. In the title of the abstract is Substantial Progress in Confronting the HIV Epidemic in Swaziland, First Evidence of National Impact. And so in this study, the study that was recently done in 2016 is a population-based HIV impact assessment. And so the authors were able to compare the incidence that was derived from that study to an earlier study that was done in 2011 with a similar methodology. And so it is like one opportunity where it is possible to compare national level measurements of incidence at two different time points that are 5 years apart. The result of that comparison is that there has been a 44% decrease in the incidence rate in the age range given here. And so the decrease has been from 2.4% to 1.5%. And it is good to keep in mind that as I introduced, that I mentioned that in modeling for South Africa, the rate that has been used as a target rate has been 0.1% per year. So it is the finding in Swaziland is still like 15 times higher than that target rate. Lastly, the reduction was actually larger among men than it was among women, but also incidence was lower in men than it was among women. So to conclude then, I will just say that yes, there has been a decline at the global level in the number of new infections between 2010 and 16. It is of 16% for all ages, and it is of 11% for adults. In East and Southern Africa, the region that is most affected in the world, the decline has been of 29%. And again, it's a little bit lower among adults, 24%. So the conclusion of this discussion is that the decline certainly goes in the right direction, but we are not currently achieving the magnitude of change in incidence that is required to meet the target. So I'd like to acknowledge my collaborators in UNAIDS people that we work with in all of the countries of the world, thank you, and the people that advise us to develop methods for doing these estimates. Thank you.
Thank you very much. Want to sit and answer questions? Thank you very much, Peter. That's great, and because we have plenty of time today and lots of people, I would like to open this first presentation for discussion, and I assume you are free to discuss both the method or the, sort of epidemiological aspects of what you showed, or their interpretation with the audience. So there are mics on each side, so feel free to.
I know there is some chairs here.
Yes, there are a few chairs in front also for those who are in the back. Who wants to open the discussion? Yes, please introduce yourself.
Thanks, Peter. Very nice presentation. Is this working? Yep.
Yes.
Just 2 points, actually. Peter, the slide you showed on transmission rate.
Close to the mic. Close to the mic.
The slide you showed on the transmission rate, very interesting. You said that was the decline you were talking about, but I think it was actually the rates themselves you were describing, 3%, 4%. I think those were the actual transmission rates as of 2016. Is that right? I just wanted to check.
Right,
that.
so I probably didn't say that correctly, but it is indeed what was shown on the slide. The numbers, including the 3 or 4%, that's the transmission rate in the last year, in 2016.
Thanks, I just wanted to be sure of that. And there's no specific target for that, right?
There is not, but maybe you will come up with one.
My other point was a very brief one, which is about the Swaziland data. It's really encouraging, and I'm very happy to see that reduction. But we must remember it's based on very small numbers, and actually the confidence interval on the reduction is 44%, I think. The confidence interval is extremely wide, so we just need to bear that in mind. We don't actually know exactly how big this reduction is. Thank you.
And thanks for that, Richard. And if I could just maybe add to that to say that it is also an incidence rate. So over the 5 years, there is also growth of that population. So that, in fact, it will make for a lesser decrease in the number of new infections per year.
All right. Yes, please.
Thank you very much, Peter. Really fabulous presentation, fantastic news.
Introduce yourself. Yeah.
Oh, sorry. I'm Rachel Bagley, and I work for WHO on prevention and testing. I think the conference is very enthusiastic about the success with treatment, and that this increased coverage with treatment is having this knock-on effect on decreasing new infections. But I also think what we're not acknowledging is also there has been, in particularly these high-burden countries, a big increase in prevention, particularly medical male circumcision. Very little mention of that in the conference, and we really need to celebrate the fact that we've nearly reached 15 million male circumcisions. I wanted, to ask you what kind of contribution you think both of these play.
Thank you for that question, Rachel. I will not answer it, though. Maybe I'll refer that back to the group. But just to say that, as you mentioned, that the decline in incidence, it cannot just be taken as only be due to increases in treatment. Certainly, there has been other interventions that have happened in that time period. And for all of them, there is good evidence about their effect. So just I will just add maybe that the levels of coverage or the level of implementation of those different interventions actually falls short a little bit, because as you look specifically, for example, at levels of male circumcision, then yes, some countries have gotten up to very high levels of the prevalence of male circumcision in their population, but others have not. Like, for example, Swaziland itself, the same study that I mentioned that from which the new incidence estimate is derived, it also found that prevalence of male circumcision is about 29%, while the target for that is 80 or 90%. So there is a long way to go. and like the country also misses out on the potential benefit it could have from implementing that intervention to the full. And maybe just also, if I can continue to add, to say that the currently observed incidence rate of, I think it is 1.4 that I said, it is extremely high, of course. Like it is, we celebrate it as a great reduction, but at the same time, it remains very, very high. And if we see that levels of treatment already also are at a reasonably high level, they come very close to 90 targets, then the question is, what else can the country do to bring incidence down?
Yeah. May I ask Marike, maybe, because you made some introductory comments, General, and we mentioned that we, as you can see, the organizers had difficulties to find a presenter to entertain the audience on the broad dimension of programmatic voluntary medical male circumcision. We heard a little bit on the first day by PEPFAR Ambassador Burks on their efforts. What is your take from the Global Fund perspective on the rollout or the continuous rollout of this part of the prevention programs?
I think very much in line with what Peter said, that it absolutely has not lived up to the expectations, and some countries have taken up. But if you look at coverage levels, it's still very low, and we also see not a lot of uptake at country level. And I know that PEPFAR discussed with Deb Burks. That PEPFAR has been very supportive of supporting voluntary male circumcision programs at country level, and uptake has been pretty low, even with a lot of support and a lot of advocacy. So I think that was one of the things I said, that we need to better understand why is uptake so low of what could be a very promising tool to the prevention toolbox.
All right, thank you. Any contribution from the audience on this? Or yes.
David Barstow.
Yeah.
Are you going to contribute on this or something completely different?
Carlos.
Could I respond? I mean, I think...
Sure. Please introduce yourself first.
Yeah, sorry. I'm Carlos Toledo from the CDC, the team lead for medical male circumcision.
Great.
15 million men have been circumcised. That is not a small feat. How can you say that it's a small feat? The target was 20 million, and we reached 15 million. So I'm not sure that we should be able to say that that's a... Yes, the coverage could be higher, but perhaps we should say, look at the impact we've had, yet we haven't reached the coverage levels that we want. But we're on our way. So I just want to make sure that we don't lose that.
Well taken. Point well taken.
Okay. Peter, you want to say something else on this? No? All right.
David Barstow from the United States. One of the very compelling features of the first fast-track modeling was this notion that if we don't make enough progress in the critical window, AIDS will actually come back. Do we still have that risk of AIDS actually coming back? Or are we on, or can we be confident that we're on a path that eventually, maybe 2020, 2030, maybe 2040, we'll get there?
Okay, let me answer or give a few elements of answer to say that certainly the trends in East and Southern Africa look very encouraging. Like they represent the strongest declines. Plus the study from Swaziland is also very compelling because it like confirms that same point. Like from what I presented also, it's clear that like some regions are completely going the wrong direction. So clearly they're not, like we're not on track there. That is very clear. But maybe one other point to respond to what you're asking about is to say that not only was it said that like if we don't have those or the efforts like grow over time, will we not see the epidemic come back, but there is also a cost element to it. Like the longer that it like takes to bring that incidence down, the more new infections there will be that will all need to be treated. So that resulting cost for treatment is just like growing higher as we fail to reduce incidence.
Can I add to it?
Please.
And on the male circumcision point, absolutely taken. And maybe when I was discussing with Deb, she was referring to the 4 countries that were presented this week, not to the entire portfolio. So would be interested in getting more news about that. And just going back to the question, I think one important point, and Peter alluded to it, we have the largest young population of sub-Saharan Africa ever. And projections are that in some countries, the young population will double over the next 10, 15 years. So halving incidence with a doubling youth population will actually mean that the absolute numbers stay the same. So I think the point is still very relevant because we see declining trends, but if you then plot that against the population growth, especially young people, it's still concerning.
Thank you. Another question?
You can hear me? Yeah, my name is Latif Shaban. I'm from the National AIDS Control Council in Kenya. I'm a board member there. Two comments. One is to understand how the Caribbean made such dramatic change. It's good for us to know that. Another one is a plea that we from the religious communities, we have been left out completely now. In the beginning, we were in the front line, but as science moved, we were left behind. And yet I believe we have a very key role to play if this knowledge can be brought into the religious communities so that we work together. I think that is the comments I wanted to make. Thank you.
Any response, Peter or Michael?
Absolutely agree. And I think because we're discussing tools that are not taken up at the rate that we want to take up, and then the human and the human behavior component is really important. Absolutely, community and religious leaders can play an important role there.
Peter, are there any more questions at this stage? No. Peter, there are two things that you don't really touch at one, not at all, I guess, and the other not in detail, at least for me. The first one is the elimination of mother-to-child transmission. Sure. We learned 2 years ago that Cuba was on the way to elimination. Then you certified it. Then a few other countries in the Caribbean, etc. What is the way to go, and how are you going to continue this effort of documenting the way toward elimination, and in which countries is this likely to be successful?
So thanks for that question. So first of all, to say that there is also a specific plan as part of this fast-track plan for further reducing the number of child infections and also for ensuring that they receive treatment just like adults do. In our most recent report that was put out last week, we actually show that today the level of treatment for children is actually lower than it is for adults. But just to respond to your question, Francois, I think that all the elements that were there in the previous plan, that they are still valid, and that levels of coverage that are aimed for pregnant women are even higher than the 1990 for the overall population. So I think that with those efforts that we should see continued success. I think if we're able to reach those higher levels of coverage. Then your question about elimination of mother-to-child transmission, that it is true, yes, that several countries have been able to certify elimination that has well-specified criteria that it's a process that is actually run by the WHO to actually go into the country and validate numbers of new infections in children that are observed, validate the measures that are put in place. What are the next countries that are going to be certified? I do not actually know that. It's a prediction. But just to quickly say something about Cuba, you mentioned Cuba, that it has had certification of elimination of mother-to-child transmission. That, while that is true, we're also, Cuba is one of the countries where we actually see evolution in their epidemic in the adults, so that certification in a past point doesn't actually mean that it will always be certified. It will need continued effort to maintain that level of low, very low mother-to-child transmission.
My co-chair will take the hat off.
No, just because I'm part of the committee for certificate countries in Latin America and Caribbean. And I think it was last week WHO, in the sense not to let no countries behind, start doing different levels of certification. Because if you do not eliminate, so you're going to work, you're not going to work anymore? This is the question. So the way that we are going to do now is having different level, gold one, platinum for countries, because when you do the report to WHO, it's a good exercise to the country to see the gaps. So I think that was a very good decision from the global commission.
It will be more costly if they have to print gold medals.
Please.
Hi, good afternoon. My name is Halle Mahler. I'm with FHI 360. I'm the director of the Linkages Project, which is PEPFAR's global investment in key populations, which I didn't hear mentioned at all. Because the question of what more can countries like Swaziland do, countries that are making such great progress, but they still have high incidence. I mean, key populations are really the group that's been missed by the programs, and the reason for that, of course, are myriad, as we all know. You have to address stigma, discrimination, the legal status of key populations in order to be able to have effective programs. But I would love next time, Peter, when you do this presentation next, is to actually show, look at all this great progress, but actually we have big groups of people who are left behind, and we can't finish without them. So I just wanted to say that. Also, if I could just make one other VMMC comment, which is that there's been no session on VMMC in this conference. There was one oral presentation during a panel that addressed all prevention other than PrEP, and it's a huge gap. I would hope for 2018 that VMMC does come back on, because we can't be discussing why Swaziland or Botswana, why those countries are still having challenges if we don't have a forum in which to do it. But actually, I was here to talk about key populations, and yeah, please, thank you.
Okay. You want to comment on that for Swazi?
I will just join the applause for that comment. But maybe just to say that, since the topic was about incidents, that it is not so frequent to find incidence rates for key populations, and especially having trans, it is just it's just much rarer data.
Yeah, but Peter, I'll take the moderator's prerogative to expand the question. In the case of Swazi, where you showed as this great success, I mean, there are obvious difficulties that don't seem to be a major problem there. I'm thinking of the migration with South Africa, where the situation is not as well controlled. And second, the delay into entry to care, the linkage issue. And the late arrival. Do you have any information how these problems were, solved or potentially solved?
Again, it's one of those questions that goes to the audience. I've never been to Swaziland, so
But you know the data from Swaziland.
Right, but I don't know specific details about their programs. So I couldn't really answer that question. But I just know that in the announcement and in the study, high levels were found for the indicators that relate to 1990, which is the treatment and care cascade.
Anybody either from Swaziland and who has part of the answer to this? No, not here. I know the surveys have been analyzed recently, so maybe all these aspects have not been addressed yet. That's the problem. Or maybe they have not been addressed with the data that are available.
Susan.
Yeah, please.
I wanted to say hi to Adeli. Peter, I have a question on the Central Asia data. It unfortunately was not surprising, but was very striking, the rapid increase that we see. Although, as you say, the numbers are not as large as in East and Central and Southern Africa. I'm wondering, are you concerned about maybe a tipping point where this gets out of control and outside of key populations like IV drug users? And secondly, are there issues within Central Asia that are barriers and concerns that are substantially different than Southern Africa. We have a toolkit and we know what to do in Southern Africa, but are there things happening there that concern you and given this rapid increase?
Right, so thanks for that question. So as I showed trends in new infections for the Eastern Europe and Central Asia region, it's good to know that most of those new infections are actually occurring in one country. The one country is the Russian Federation. It represents about 80% of all new infections in that region. So that while it is true that at a regional level, because of one country being so dominant and going in the wrong direction, there is actually some countries in that same region that show declines in new infections. And then your second question, where you ask about like what could this be due to, I think that like very clearly it will have to do with the dominant mode of transmission, which is like through people who inject drug use, and that it is a lot of must be due to like policy not being right to address those issues and that transmission. So for the like unless that like changes, yes, there will be risk for further spread, and there is also the risk, as you say, that like transmissions will go beyond people who inject drugs.
Maybe it would be nice to see that, to show that some of the Eastern Europe and Central Asia countries do better than others, and on the positive side, yeah, from the data perspective. Probably last question.
Good afternoon. I'm Albert Machinda from Zambia, PSI and SFH. I think I have a comment and a question, and I think my question would be to you, Peter. From the information we have, do we have any sense of how much of our infections, especially in the high-burden countries, how much the key populations contribute to that HIV burden? And I think my general comment is also back to the VMMC issue. I get a sense that generally the conference has sort of looked in one direction in prevention and sort of forgotten where we're coming from and what has also contributed to where we are right now. And I think that's a challenge that we need to look at instead of keep concentrating on one issue at a time. Let's find ways of making sure we integrate all those issues, and I think as a whole, some would contribute to HIV prevention. Thank you.
So thanks for the question. It's so certainly there is like an important contribution of key populations. I think that generally one finds that like the higher prevalence is in a country, the smaller that contribution is as a proportion, because it means that there is a lot of spread in the general population. I think in our recent report, I think we mentioned that for regions outside of sub-Saharan Africa, that about 80% of all new infections are in key populations. In sub-Saharan Africa, there will be a much smaller proportion, plus it will vary very importantly, say, from Senegal all the way down to Swaziland, for example, where you go from 1% prevalence to about, I think, 28 or something percent prevalence. But like I'm aware that like my organization has like promoted in the past studies that were called mode of transmission to try and get a sense of what the contribution is of those different population groups. I think that John Stover, who I've seen in the audience, like has actually done an exercise like that for Zambia. I can't remember exactly the percentages, but I think it is maybe in the order of 3-4% for the different. John, you want, or maybe I'm not sure I'm allowed to ask you to speak to that.
Yeah, you, please. John, go ahead.
Hi, we have been applying a model called incidence patterns model that tries to use information from national surveys about different population groups and then information from scientific studies about incidence in different populations to try to estimate the source of new infections. And we've been applying the model recently in some of the countries in East and Southern Africa. And for Zambia, if I remember correctly, the estimate was that the proportion of new infections coming from key populations was about 5%. But you'll have to remember that that the number of new infections is based on several things. One is the population size, and then a second is the estimated incidence in that population. And I think we have very poor estimates of population size. Sex worker estimates may be okay. MSM estimates, absolutely, no good knowledge at all, and people injecting drugs even worse. So that's what we're estimating right now with the models, but it's highly colored by the lack of good information about population sizes.
Thank you very much. Okay, if there is no more question, we will move to the second part of the panel and the second part of this session. Adele.
So now we change topic, ending HIV transmission among people who use drugs, and we are gonna hear from two cities, New York and Vietnam. So first, from US, Dr. Desjarlais. He's a leader in the field of AIDS and injecting drug users, and he's published extensive topics on that, and he's very active as international research, and he has been collaborating in many studies in different countries. So
okay,
you have the floor.
fine. Thank you. Yes. This session is titled Towards Elimination, and I think with the key population of people who inject drugs, elimination of HIV transmission is a realistic goal. Clearly, as Peter mentioned, there are countries where the policy environment is absolutely terrible, where the policy drives transmission. But once countries get their policies correct, which may take a while, may take decades, but once that does occur, we do see very close to actual elimination. And the presentation today by two of us will look at what has happened in New York City and then what we're trying to do in the city of Haiphong, Vietnam. We have no conflicts of interest. There are many areas that experience very, very rapid transmission and rose to high HIV prevalence among people who inject drugs. Prevalence rates of 50% or higher have been observed in the areas mentioned here, and incidence rates of 10 to a maximum of 50% per year have been observed. So the potential for a public health disaster exists for HIV among people who inject drugs. We've also seen areas that avoided HIV epidemics among people who inject drugs, the United Kingdom and Australia in particular. In these places where HIV prevalence never exceeded 5% among people who inject drugs, people who inject drugs were well informed about HIV risk. They had very good access to sterile injection equipment, usually through syringe exchange programs and through pharmacy sales. And the community viral load, the percentage of the injecting population that was HIV positive and capable of transmitting to others, was kept at 5% or less. We've also seen areas where the HIV epidemic has ended among people who inject drugs. So far, these are all in high-income countries, and one of the things that we're currently working on is trying to replicate this in middle-income countries. Ending an epidemic basically means going back to the conditions similar to the United Kingdom and Australia, where epidemics didn't occur. That means you use a combination of prevention and treatment, needle syringe exchange programs, condom distribution, antiretroviral therapy for HIV-infected people who inject drugs, Medication-assisted treatment, methadone and buprenorphine can also be very helpful, but is not absolutely necessary. If there's an epidemic of cocaine use or amphetamine-type stimulant use, you can still do an awful lot to reduce HIV transmission among those drugs for which we do not yet have effective medication treatment. The data from New York comes from what we call our risk factors study. The subjects are recruited from people entering the Mount Sinai Beth Israel Hospital in New York City. This report focuses only on people who've injected drugs. The participation rate in this study has been very high. About 95% of the people asked to participate in the study have participated. And we have a long risk behavior questionnaire and HIV testing. This graph shows a historical reconstruction of the HIV epidemic among people who inject drugs in New York. The first part in red shows the rapid spread of the virus. You'll note that this occurred before HIV or AIDS was even discovered. We did have blood samples that were collected and frozen that we went back and looked at HIV infection, and the first infection we found was in 1978. And we saw a very, very rapid rise up to about 60% prevalence within about 6 years. Then we saw a period of relatively stable high prevalence in the 60 down to 50%. This stabilization of the epidemic occurred because the drug users learned about AIDS and they voluntarily changed their behavior. They did this before there was any official government action to address the epidemic. Then from the early 1990s through about 2000, the city did implement syringe exchange programs, and we saw a dramatic reduction in HIV prevalence. The implementation of the syringe exchange programs was also associated with a dramatic reduction in incidence. Incidence went from 4% per year to 1% per year, so that we saw a 75% reduction in incidence when we implemented the syringe exchange programs. And then more recently, we've implemented ART. That led to an initial rise in prevalence because the death rate went down dramatically. And we've now seen continued reduction in prevalence to now we're down under 10%. So the key events were the dissemination of information about AIDS risk behavior that occurred in the early 1980s, the implementation of our needle syringe exchange program in the mid-1990s, and implementation of treatment as prevention beginning in the early 2000s and continuing up till today. Currently, we have achieved the 90-90 goals for people who inject drugs in the city. We still do see some sharing of injection equipment. About 15% of the people who inject who are HIV negative engage in receptive sharing. We have not been able to come anywhere close to eliminating people who are negative, HIV negative, sharing injection equipment. But where we have seen the dramatic success is in the percentage of the injecting population who are HIV positive, engaging in distributive sharing, passing on their used needles and syringes to other injectors, and not on antiretroviral treatment. This is now down to 0.2% of the injecting population, so that we've achieved control over the epidemic, not by getting people who are negative to stop sharing, but by reducing the transmission capability within the population. by identifying people who are positive, convincing them not to pass on their injection equipment, and getting them onto antiretroviral treatment. The current situation, we recently completed a cohort study to estimate HIV incidence. We found no HIV seroconversions in approximately 400 person-years of risk. So the confidence interval goes from 0 up to 0.1 per 100 person-years at risk. The City Department of Health also keeps track of all newly diagnosed cases of HIV among people who inject drugs, and that tracks very well with cohort studies of incidence. Recently, the newly diagnosed cases as a surrogate measure of incidence would give us a rate of 0.4 per 100 person-years at risk. So basically, we're finding about 40 new cases of HIV infection among people who inject drugs, and the population size is about 100,000 people who inject drugs. So we have a key population of 100,000 people, and we're getting about 40 new cases of HIV per year. And the Department of Health has now adopted an official goal of eliminating injecting-related HIV transmission. This is certainly nothing we would ever have expected in the early days of the epidemic, when we had 50 to 60% prevalence, and we had, during the rapid spread, we had an estimated incidence of 13 per 100 person-years at risk. However, we are also experiencing an opioid epidemic throughout the U.S. and in New York also. This is occurring among people who transition from opioid analgesic use due to overprescribing of opioid analgesics for pain control. And then once their dependence on those analgesics became pretty high, they couldn't afford the opioid analgesics on the illicit market, and they've changed to heroin and fentanyl injecting. We clearly need to reduce the very high number of overdoses due to heroin and fentanyl injecting. We now have about 35,000 fatal overdoses per year in the U.S. And with this increase in injecting drug use, we need to avoid a resurgence of HIV transmission. We do have the one example of Indiana, where HIV got into a population of new injecting drug users, and there were no prevention services, and we saw 183 new HIV infections within a period of about a year. Okay. So in conclusion, it's possible to greatly reduce and maybe even eliminate injecting-related HIV transmission. The key factor in doing this is to reduce the transmission potential among HIV seropositives rather than trying to get everybody to stop sharing. This does require good community access to sterile syringes. Medication-assisted treatment is very useful. We need behavior change by the HIV seropositives and to support them in that, and then ART treatment as prevention. And the final conclusion is that it's absolutely necessary to monitor changes in patterns of drug use. Simply because you've achieved great results at one point in time does not mean that that situation will continue indefinitely. And now I'd like to turn to Dr. Huang, who will talk about trying to replicate the success in New York in a middle-income country, where resources are obviously much more limited, and the stigmatization of HIV and drug use is also a major problem. Dr. Huang?
Yeah, I would like to introduce Dr. Duan Huang. She has been working for the Haiphong University of Medicine and Pharmacy in Vietnam, and she also has been working for Harvard AIDS Initiative in Vietnam as a medical officer. And we are going to have the discussion after her presentation, after presentation of the two cities. So you have the floor.
Thank you, the chair of the symposium. Good afternoon, everyone. I would like to thank Dr. François Davis, Director of ANS, and Dr. Khoti Hayoing, Director of SCDI in Vietnam. They give me the honor opportunity on behalf of DRIVE team to present the perspective ending HIV epidemic among people who inject drugs in Hải Phòng, Vietnam. Here we have no conflict of interest to declare. As you see here, Hải Phòng is in the sea coast in northern Vietnam. Hải Phòng is one of three biggest cities in Vietnam, and we have an estimate of 2 million population. HIV epidemic initial speed of HIV among people who inject drugs occurred in 1990 in Hải Phòng. And the result from the IBBS through from 2006 2016, we see here the declining HIV prevalent among people with inject drug from 66% 2005 and 44% in 2013. The national response to the population of drug, the people who with inject drug, by relied on compulsory rehabilitation center, but it's not effective. In Hải Phòng, we have implemented the intervention to get people with inject drug. The needle syringe exchange program started 2007, and since 2008, Hải Phòng is the first open methadone clinic and increased coverage in 2017. We start ART treatment for HIV infection since 2005. It's really new, and now it increased coverage in 2015. The result we found from the early driver projects to show our evidence for we are on the right way for prospective ending HIV epidemic among people who inject drugs. First phase drive initiation phase called dry-in. We enrolled 603 active people who inject drugs using community-based ADS. And after that, we follow up 199 HIV negative for 1 year. And we run the follow-up to feasibility of people access to ART and MMT treatment with the support from peer group, 51 HIV positive. The second phase after feasibility, we run the driver project with the ADS implemented to address the HIV. Increasing HIV screening coverage through 4 annual last ADS. With the 3 first ADS, we last the screening HIV and access them to ART and MMT treatment. The early result of driver ADS 1 completed in January 2017 with 1,385 enrolled participants. You see here the the testing of drug, the people with inject drug, HIV testing, we found the prevalent prevalent HIV prevalent at 2014 ADS was the 25% and 30% at 2017 ADS. But the prevalence of HCV positive is very high, 66% at 2017 ADS and 70% at 2017 ADS. We do the cell report sharing needle. We found that here at ADS, the 2014, about 5.5%, and it's the similar at ADS 2017. But at earlier analysis, now we need to check the correspondence between cell report and the data. Current people on AIT in our participant, you see here at ADS 2014, 39%, and 68% on AIT at 2017 ADS. Now we see the HIV evidence in population viral node. In 2017 ADS, now 17% people on AIT undetectable viral test with cutoff to 1,000 copy per milliliter is a 76%. And with the cutoff 50 copy per milliliter is 68%. That we can find that population viral loss in people with inject drug is 7%. It's much lower than at phase feasibility phase dry-in, 50%. We found that no HIV seroconversion in dry-in and between two ADS among 200% year of follow-up. HIV prevalence is 70%, and we found the very high prevalence, and also we found the HCV seroconversion 21 per 100% year. Our the main intervention we run here is the access for HIV positive to AIT treatment and MMT, and with the support from peer group. And we see here during 9 months, first 9 month follow-up, the rate of follow-up is that 84%, and from M0 to M9, there are 90 participants have been on AIT with the support of peer group, and the percentage of people on active AIT now is the 82%. MMT, we have a success, 133 participants on MMT, and right now in our study population on MMT is 50%. And you know, right now in Vietnam, we are on transition period from free AIT program to covered by health insurance. But it is very difficult for our participants when they have not ID card, is to embarrass them to buy the health insurance. And with the support of peer group, they help them to get the ID card and buy the health insurance. So the percentage of participants have a health insurance is 51%. To own the intervention to get the broad will eliminate HIV epidemic is we know here is the proportion of HIV testing for new and unknown HIV infection in the city is remain low. And as I just said, Vietnam right now in transition from the free AIT program to covered by health assurance. So from our experience on managed patients, the delay HIV access because the many people with inject drug cannot get health assurance because they have no, cannot get health ID card. Likelihood of increased loss of follow-up of patients on AIT who have to disclose their AIT, their HIV status, because they have to buy health assurance to cover their care. So it's very difficult. At the moment, they have to transfer from free AIT to coverage by health assurance. As you already heard from the good example of New York City, they do eliminate HIV epidemic, and we do the exam in the Vietnam in the very low resort limited. We continue testing of the intervention using a very large sequential ADS as a testing tool to cover the majority of people with inject drug. With the support from peer group, the people with inject drug to access MMT and AIT treatment. Drive goal for next 4 years, maintain very low HIV incident and reduce HCV incident to get the role. We hope we have a good result in 4 years. Thank you for your attention.
Thank you very much. And so we're going to open for discussions. And please say your name and make your question. We have only 15 minutes. And to start, I would like to put some issues in the table. Maybe for Peter Gies again. In some countries that we do not have a lot of people that inject drug, we are starting using people who use drugs and not injectable ones, because we know that the vulnerability of alcohols and other drugs are important also. So to separate these two issues, I think is important for some countries. And another topic that I really appreciate your data is the adherence of people that use injectable drugs to the treatment, and I think is a good topic also to discuss with the plenary.
Yeah, to address the comment on people who use drugs being at high risk, they clearly are, and there are places where people who use drugs without injecting have higher HIV prevalence than people who use drugs by injecting. Unfortunately, our classification of routes of transmission does not really pick up people who are using drugs and becoming infected sexually, so that it becomes very, very hard to monitor that. It requires special studies, but we have seen great results in trying to reduce people HIV infection among people who smoke crack cocaine in New York City, where we have special studies, and we did do a cohort study of people who smoked crack cocaine and sniffed heroin, and found incidence of 0.1 per 100 person years at risk also, and that was mainly through condom distribution and ART. So it really is possible to reduce HIV infection among people who are very intense users of non-injected drug use. And the methods that we that work with people who inject drugs can be effective with those also.
Okay.
Anna?
My name is Anna. I'm from the... Eita. My name is Ana Roberta. I'm from the Department of STI, HIV, AIDS, and viral hepatitis. I just, from Brazil. I just want to, I have some, couple of comments. I like very much the presentation, but first of all, I would like to know the source of the data that you mentioned about Brazil, saying that Brazil is between the countries that have HIV prevalence between 10 and 50%, not you, not Peter. Don.
Okay. Right.
Yeah, him. I have one for you too.
Okay.
Because as far as we know in the Ministry of Health, HIV prevalence among IDU were 80%, 8% in 2009. Actually, we carried out a RDS study in 2009, and we have a very hard time trying to find IDU seeds, and we started we thought in an RDS study, but we couldn't find seeds, and we carried out and studied with people who use drugs, and the HIV prevalence in this study was 6% among people who use drugs and 8% among IDU. So we know that we don't have, I don't know where is from where you have this source. And what's happening is that the drug scenario in Brazil changed a lot.
A little bit quick.
Okay. I'm trying. A lot, and now we have crack users there. And we almost don't have people who use drugs. People who use injectable drugs. And I have just, by the way, I have just one more comment because I just want to suggest to UNAIDS to use rates instead of numbers, so we can have, we will not have this problem about the size of the country in the region anymore. So I think in the next report we should do that.
Thank you, Anna.
To respond, Brazil had a very large population of people who injected drugs with high HIV prevalence in the 1980s and 1990s. So that, there has been it's not anymore. People have stopped injecting as the primary route of using drugs, and they've gone to smoking crack. And so now there are very few people who inject, and HIV prevalence is quite low among people who inject. So that it is an example of a country where there were a lot of people injecting cocaine and with high HIV, and that problem has changed. It's now a problem among people who smoke crack, but there is not a real big problem of HIV among people injecting the drug in the city compared to what it was like in the 1980s, 1990s.
Thank you for clarifying that. Peter?
Right, so Ana Roberta, thank you for that suggestion. Let me just say that I will say two things. One is that clearly both rates and numbers are of interest, because say somebody who's managing program and needs to plan how many people need to be treated, that person needs to know how many people that represents the rates, right? But if I can just make advertisement to say that you can find both rates and numbers on AIDS info, which is on UNAIDS website. Oh, it's not in the report. You want the report to be longer? Okay, thank you.
Okay, well noted, Peter. Yeah. Any more questions from the floor? I have a question to both of you regarding HCV transmission. I mean, you obviously are now targeting more the reduction in HCV transmission than HIV. Don, you didn't mention really the way HCV was transmitted in your population and the difference that could happen between countries or places like New York and Haiphong. So can both of you comment on the HCV issue?
Sure. HCV is transmitted through blood-to-blood contact. It is possible to transmit it sexually, but very, very difficult. So HCV can be used as a biomarker for injecting-related transmission. Unfortunately, it requires very, very little blood-to-blood contact. That if I have a cut on my hand and I reach over and put pressure on my friend's injection site to stop the bleeding, that may be enough to transmit HCV. If people share the drug preparation equipment, the cookers and cottons and filters, that can transmit HIV. In Haiphong, people inject using Novocaine to dilute their heroin. They share those Novocaine capsules because they don't need to use an entire capsule for one injection. And the Novocaine capsules, they become infected with HCV and transmit HCV that way. In New York, we had about 90% HCV prevalence before we started our syringe exchange programs, and that went down to about 70% currently. So needle syringe programs do reduce HCV transmission, but it is still at an unacceptably high level. Huang, do you want to mention the Team C efforts?
The early data from the driver, we have a very low HIV, no case seroconversion of HIV, but very high prevalence HCV and incident. The reason we have still to looking for and find out many quality we is running. Sorry. To find the reason why the low HIV incident but the high HCV incident, and with the very early data show that the people still sharing the equipment to use the smoke, and they do the the skulker with the peep to smoke cocaine, and they said the water Novocaine when they use it, and almost our participants don't understand why they have infected HCV. They think only the HIV infection, but they have no idea about how HCV can transmit from between the people with insect drug, because they said that they don't share any needle and syringe, but in fact they using the same water or Novocaine or the same something when they smoke.
There's a growing problem of smoking methamphetamine, and they share the pipes for smoking methamphetamine, and you can transmit HCV if you have burns and open sores on your mouth if you pass a pipe back and forth.
So the last question, because we are almost on time to close the section.
Hi, my name is Teresa Gamble. I'm from FHI 360, and I live in Durham, North Carolina. And you mentioned the opioid epidemic in the U.S., and I have two questions related to that. One is, do you have any speculation about why the outbreak in Indiana hasn't happened everywhere? Because it's, I mean, just the numbers are crazy. And then second, because the Indiana outbreak is a rural setting, not urban like you, I was wondering if you had any advice about where needle exchange programs might best be utilized. Thank you.
After the Indiana outbreak, there has been serious efforts to provide HIV prevention in rural areas, and those are sort of just getting started, but it's clearly good that they have started. One of the unlucky things about that Indiana county is that it's on a major trucking route between Louisville, Kentucky, and Indianapolis, and so the thinking is that there were truck drivers who stopped there. We do know that there was a lot of selling sex at the truck stop, so it's quite likely that HIV got introduced into the sex market, which had a lot of people who were addicted and injecting drugs, and that it therefore quickly spread. We do have some syringe exchange programs operating in rural areas. They mostly operate through secondary exchange, that I will have a syringe exchange that may be only open a few hours a week or so, or I may drive around in my car distributing syringes. And I try to find leaders in the injection community who will exchange very, very large numbers of syringes, 200 or 300 or 400 at one time. And they then distribute those syringes out into their peers, their friends, so that you really have to involve the injecting community to do large-scale exchange of sterile syringes.
Thank you very much. It's just time to close. I'd like to thank the presenters who did a great job in not only presenting but also answering your many questions. Thank you for them. This session was really intended to discuss where we were toward HIV elimination and beyond the 319 numbers that we know and that have been positively presented up to now. You have seen today that there are still worrisome figures and no way to stop, and probably the need to enhance in many ways our global scientific evidence-based solutions to local situations. Thank you very much.